Good afternoon. This is Frederick Hayden. I'm Emeritus Professor at the University of Virginia, and it's my pleasure to welcome you to this Medscape educational event titled Shielding the Vulnerable, the Latest in COVID-19 Prevention Strategies. I want to point out that this event is supported by Shionogi, and that I've been a non-paid consultant at Shionogi over the last decade with regard to the respiratory virus antiviral portfolio, although they have provided travel support for presentations at scientific conferences. I'd like to introduce my faculty colleagues. First, Shmuel Shoham is Professor of Clinical Medicine at Johns Hopkins University School of Medicine in Baltimore. And then Dr. Allison McGeer is Professor of Laboratory Medicine and Pathobiology at the University of Toronto in Toronto. Allison and I go back a long way because I interacted with her colleagues back in the first SARS event, during which Canada was disproportionately impacted with over 250 cases, including 3 deaths in healthcare workers. And this has been a theme really with subsequently with MERS and of course more recently with COVID-19 about the impact, especially early on, in healthcare workers. The next slide will just remind us that we're only about 3 weeks away from ID Week, and that there'll be a number of presentations there that are relevant to respiratory virus infections. I note that there'll be sessions, both abstracts as well as talks with regard to COVID and long COVID, as well as, of course, on influenza. Mike Osterholm, who is speaking in the opening session, will join Richard Webby from St. Jude and be giving us an update on H5 infections. Now, Mike, of course, as you know, is at the University of Minnesota and is also the lead on CIDRAP, as well as the vaccine integrity project that's very important with regard to making sure that we have our appropriate vaccine strategies in place. There are also presentations with regard to respiratory virus infections in transplant recipients, and a late breaker session on Monday with regard to advances in new treatments for RSV and influenza, including one on a novel zanamivir conjugate, which is being developed for prevention of influenza in high-risk patients. So with that background, let me then ask Shmuel to lead us with an initial discussion with regard to therapeutics for COVID-19.
Great, thank you. So the thrust of this slide is you got to choose the right patient, the right drug at the right time. And what you're looking at is a parabola, and the concept was developed by Arturo Casadevall and Lisanne Porofsky many years ago as a general way of looking at host-pathogen interactions. But I'll walk you through it. On the one hand, you have damage. That's how much the patient and their tissues and their overall health is impacted by an infection, in this particular case, COVID. And on the other hand, you have the immune response. On the one hand, you could have very little immune response. On the other hand, you could have an exaggerated immune response. And then, like the Goldilocks bears, you can have the sector 2, Roman numeral 2, where you have just the right response. And as we know, in those patients, which make up the vast majority of patients with COVID infection, no treatment is needed. They're going to get better on their own, and no treatment is needed. But as the population has gotten more and more immune to the virus, that group 2, has grown larger and larger. However, there's still going to be patients in sector 1, which is patients with very poor immune response. And the poster child for that, I would say, would be somebody that gets rituximab, for example. And the virus is going to proliferate and cause damage, and those patients may smolder on along for a long time. other patients which may not be as intensely immune compromised, particularly in the B cell compartment of the immune system, and particularly this happened early on in the pandemic, will get an infection, and then they'll have a high viral load, and then that will activate their immune system to jump right from sector 1 all the way to Roman numeral 3 at the top, where it gets red and angry and orange in color, and that's where they develop respiratory failure, cytokine storms, multisystem inflammatory syndrome. And you saw many of those patients that they would initially get the infection. It looked like they were getting over it, and then just as they were either getting better or not getting better, they would get sick very quickly and go into a hyperinflammatory response. We still see some patients like that, but much less frequently. And then the other thing that can happen is there's going to be patients that have chronic illnesses such as chronic lung disease, heart failure, where the viral load can be high, the infection can be present, but then they tip over into uncontrolled heart failure, into respiratory failure from the compensated disease becoming decompensated disease in terms of their end organ disease. So what are we going to do to get as many patients into sector 2 as possible? So the combination of vaccination, natural infection, I think that the vast majority, maybe everybody, has had a combination of a vaccine and or natural infection at this point. So getting as many people into that, hoping that the virus doesn't mutate so that the immunity that already exists for those people in Roman numeral 2 it can continue to be strong and protective. And then finding those patients that are at a risk for progression to severe disease and preventing them by strengthening their immune system to the extent possible. That could be a reduction of immunosuppression. If feasible, that could be vaccinations while potentially holding some immunosuppression so they get vaccination, repeat vaccinations, and then hopefully we used to have drugs that were effective as pre-exposure and post-exposure prophylaxis. Now our armamentarium is much narrower, but we hope that we can have drugs like that again so that we can identify those patients that it would be really bad for them to have an infection and prevent that altogether. I'm going to hand it over to Dr. McGeer to talk about some of the patients that might not fit into sector 2. And I also believe Dr. Hayden has a question for me.
Well, I wanted to ask you whether there have been any recent updates with regard to the IDSA treatment guidelines for COVID-19.
Sure. So I appreciate that. I am a member of those guidelines, and I think one of the most significant things that has been updated is in the issue of pre-exposure prophylaxis. And there is a recommendation for a specific group of patients to receive pre-exposure prophylaxis with a monoclonal antibody, but and that monoclonal antibody is effective against some of the viruses, not of the others. But the most important thing is that there's been a risk stratification developed, identifying patients at highest risk for progression to infection and to severe infections. And those include some of the patients that you would expect, stem cell transplant recipients that have gotten the transplant within a couple of years, patients with graft versus host disease, that's an advanced graft versus host disease, patients that are hematological malignancies on therapy, lung transplant recipients, and then patients that have very few peripheral B cells, either because of treatments, B cell depleting agents, or because of CAR T therapy, again, that may have caused them to have hypogammaglobulinemia and low function of their lymphocytes, and then also recipients of abatacept. So those higher risk immunocompromised patients, it's really not a good thing at all for them to get COVID, and those would be the patients that one should focus on mostly in terms of pre-exposure and potentially post-exposure prophylaxis.
Thanks very much. So over to you, Allison.
I was just going to ask you, Dr. Hayden, is there any prospects for new monoclonals that are going to be more effective for prophylaxis going into this season?
I'm not informed on that, and that's one thing I hope to learn at ID Week.
Yeah, I mean, I think all of us are kind of hoping, but the silence is, I think, means at least for this fall that it's probably not going to be an option for people. And that, of course, leaves us with the challenge of using something that is not licensed or of early treatment with Paxlovid. And early treatment for those highly immunocompromised patients clearly has an impact, even if Paxlovid or oral therapy is all you can deliver to people. So it is really important for those folk to know that A, they need to get vaccinated to reduce their risk of getting infected and getting serious infection, but B, they need to know that if they get an upper respiratory tract illness, that they find out whether it's COVID and that they make sure that they get on early treatment.
This also raises the issue, if someone does become infected, especially these B-cell depleted patients, when do you try to use, in addition to the direct-acting antivirals, some sort of immunotherapy with, hopefully with neutralizing antibody, even if it's IVIG. I'm not sure if you've had experience with convalescent plasma, for example, Shmuel.
Yeah, so I thank you for asking that. I have a lot of experience with convalescent plasma, and here's sort of the way that I would look at it. One is we did a study for post-exposure prophylaxis with convalescent plasma, and it didn't really work. And did it not work because we didn't do the study well? Possibly, or did it not work because by the time that you deliver an antibody to the nose, it's not really all that effective in preventing the progression of disease from infection to actual disease. But it didn't work. In terms of monoclonal antibodies, when they were effective, when they worked, there was a window of time where it was effective. Evusheld was the first one, and now pemivibart. But again, the problem is that these viruses are swarms of viruses. They're not one individual virus, and they're constantly mutating. And as fast as we are able to develop these, I say we, I'm not the one developing, as fast as the companies are able to develop the monoclonal antibodies, these viruses do pick up resistance to it. The resistance is probably not generated by exposure to the monoclonal antibody. It's probably generated from interactions with the immune system, because all of the monoclonal antibodies were generated from people's B cells and then turned into a monoclonal antibody. So if a monoclonal antibody is stable and has a high level of activity, then I think it would work. But there was a question from the audience, what are our thoughts on pemivibart? So I can share my thoughts on it, is that if it's effective against the virus that's circulating in your community, then it's probably going to protect you. If it's not effective against the virus that's circulating in your community, then you'll probably break through. In terms of treatment, IVIG and convalescent plasma, I think I'll start with convalescent plasma. What does convalescent plasma have? It has IgM and IgG, but IgM is probably the most important part that is protecting people. So if somebody has an infection that is active and they cannot make their own antibody, then giving them IgM that is neutralizing through the virus is going to be effective. If, on the other hand, they're already making their antibody, then probably it's not going to be all that effective. Maybe some immunomodulatory activity, but it's probably not going to be effective. If you have a patient that has a decent immune system and you give them remdesivir versus remdesivir plus giving them an additional monoclonal antibody or passive immunotherapy in the form of convalescent plasma, probably not going to give you all that much more. I think if you chose one or the other, then it would probably work, but probably wouldn't work. Now, regular plasma that you get in the blood bank is essentially convalescent plasma right now, because people that can donate blood, they probably have high titers of neutralizing antibodies. So whereas the FDA still demands that it says high titer convalescent plasma, between the three of us, if you went to your blood bank and say, hey, can you give me a unit of plasma, the same stuff you gave as FFP, it'll probably be the same thing. And then finally, IVIG, the advantage of IVIG is that it's got lots of antibodies from lots of people. So you have a lot of different, not just one donor, but tons of donors represented. The downside is it is something that was generated probably 6 to 12 months ago in terms of collection. So it may not be the bespoke monoclonal, the bespoke antibody. And then the other thing is that it's IgG, and I think IgM is really where most of the action is in terms of neutralizing activity against COVID. All right, that's probably more than you ever wanted to know about convalescent.
Oh, thanks, very helpful. Allison, you want to comment then on some of the risk groups, please? You're muted at the present time.
Muted, apologies. Maybe we could bring the slide up on the risk groups. I think just to go back to really the focus of treatment this fall needs to be on people who are either aged and frail, and aged is probably now in the 85 to 90 category. Really, vaccine and infection have done a very good job of improving outcomes across the age span. People who have, as Dr. Shoham just described, the very high risk groups from IDSA transplants, including lung transplants, people with very low levels of B cells, people with hematologic and immunologic malignancies. Those are the people who really need the focus this fall and winter to make sure that if they get something that might be COVID, that they recognize that it might be, you find out whether it's COVID and you get them onto early therapy, because they're the people who are still going to have trouble. I guess you would also label people who've not been vaccinated to some degree in that category, because even 2 infections is probably not as good as 2 infections and 3 or 4 doses of vaccine. But really, it's that IDSA list of very high-risk conditions are the people that we need to be focused on and worried about this winter.
Yeah, the next slide, please.
I'm very interested in those patients with the cardiovascular disease and the ones that are just hanging on in terms of a stable state, staying out of the hospital. And we know from RSV and influenza that those are the kind of people that end up in the hospital with those infections. I think COVID is still evolving, but do you get a sense that those are some people that you also see when they get COVID?
I don't have, I'm going out on a limb here. I have not been really conscious of cardiac complications of COVID as I have been of flu and RSV. Very clearly, flu and RSV predisposed to heart attacks and also strokes and trigger congestive heart failure. COVID will certainly tip you over, as you say, if you're just hanging on for any reason. But I'm not sure that we've demonstrated yet that it's associated with that really high early risk of cardiac disease.
Yeah. Now, one study I saw from Japan a few years ago that was really intriguing to me, it had to do with frailty, which takes into consideration some of these, and that if somebody was frail and they ended up in the hospital with COVID, they were much more likely to end up not going home than either going to a subacute facility or dying than if they were not frail.
I think the challenge here is that I'm not sure how much treatment of those patients help. Vaccine, unquestionably. Unfortunately, if what you have is oral therapy available to you, then that will prevent you from dying if you get infected with COVID. It's not going to make your symptomatology in the first 6 or 8 days much better, and doesn't help that much with reducing viral concentration in that time period. And it's probably that degree of illness in people who are really older and frailer that gets them into trouble with getting in the hospital. So those are people where you really want to make sure, two levels: A, that they get vaccinated themselves, but they get protected by the people around them. So household contacts, caregivers, people around them are protected from getting disease, because I think you're really, the most effective thing to do for those people is to protect them from getting infected in the first place. I'm not sure we can do a whole lot for them if they do get infected. Not that one shouldn't try and be careful and work at it, but is vaccine for those people and people around them is really important.
That's a very helpful segue in terms of considering what are some of the other prophylaxis strategies that one could use. Of course, we've talked about vaccine, non-pharmaceutical interventions, but there have been a number of placebo-controlled antiviral trials for prophylaxis, and I've tried to summarize these briefly on this particular slide. Now, I point out that none of these agents are currently FDA approved for COVID prophylaxis, but I think it's informative to look at some of the trial results. With the dual antibody therapy with casirivimab and imdevimab, given once subcutaneously, these first four are post-exposure prophylaxis studies done in household settings, so that these are household contacts with close exposure. That was very effective in terms of reducing the risk of developing COVID-19. A follow-on study that was done with Paxlovid, you can see for 5 or 10 days, with a large number enrolled, found some evidence of infection, but it missed its primary endpoint. So the maximum with a 10-day course was a 35% reduction. Molnupiravir had even a smaller effect, but it was only given for 5 days, probably insufficient duration of exposure, because we know that most transmission events within the household setting occur within that 10-day period. And the most recent direct-acting antiviral, this is another 3CL protease inhibitor, Incitravir, which is approved in Japan for treatment of mild to moderate COVID, when given orally for 5 days. And it was only 5 days because it has a much longer plasma elimination half-life, was effective for post-exposure prophylaxis with the, as you could see, the relative risk reduction of 67%. And there have also been 2 fairly recent publications with the intranasal approach, but these are pre-exposure prophylaxis where the sprays were given for prolonged periods. You can see 2 months with the Zelastine, which is a H1 antihistamine, and 3 months with the intranasal recombinant alpha-2 interferon. In both were relatively small size, but they did see significant reductions. I think that these are interesting studies that I hope will be repeated with much larger numbers going forward. So with that background, I just wanted to take my faculty colleagues through a few case scenarios here. If I could have the next slide, please. So you're a medical director of a nursing home and are considering adding antiviral post-exposure prophylaxis for SARS-CoV-2 to your institution's formulary. What are the factors you consider in making the decision? Allison, you work in this setting on a regular basis, so perhaps you could start.
Well, I think it first starts with what level of protection do you think your residents have, which is how many doses of vaccine they've had, what the adherence to vaccine recommendations for this fall have been among your residents, their caregivers who come in from outside of the home, the people who work in the home, because that's what tells you about what their base risk of infection is going to be. We're just sitting right on the edge of maybe having some therapy that will really work well to stop outbreaks in long-term care homes. So I think the first thing for medical directors in long-term care homes is to keep a really careful eye on, if the FDA approves ensitrelvir, that would be, give us something really good. If more data comes out on azolastine, That's another possibility. You do need to think ahead of time because both of them do have some drug-drug interactions. Not nearly as bad as niraparib or ritonavir, and you do have to remember that despite the drug-drug interactions, azelastine is available over the counter in much of the world, including Canada. So I think that's a marker of you don't have to worry all that much. To me, in long-term care, the big risk with these antihistamines is, fatigue and tiredness, and that may be a little bit difficult to assess in long-term care residents. So I think it's worth getting your facility prepared for the possibility that there may be prophylaxis, because we all really like to have, same way we use oseltamivir for prophylaxis routinely for influenza outbreaks, extraordinarily effective at stopping outbreaks and getting things back to normal in the home quickly. And hopefully these anti-COVID antivirals will do it. So I think it's worth having the discussion among the home and among the physicians who care for residents in the home about whether you might, for instance, want to try azelastine and talk to people about trying it for prevention if you get into an outbreak. I think you want to have the discussion about if ensitrelvir is SCA approved, when there's more data, is that something you want to have a discussion with residents and their caregivers about? Because come February or March of next year, it may be that it will be possible to access some of these drugs and that they will be effective. But, baseline, it is, where we are at the moment with long-term care is trying to get vaccine rates as high as possible, making sure that people are aware of disease and outbreaks, so you detect outbreaks early, and having good implementation of other preventive strategies in the home for the winter.
Do you have anything to add to?
I think that the points that she made are right on target. And then the other thing I would add is the number needed to treat and the number needed to harm. Those are data that we would need to have. And that is an evolving situation, because right now, if the viral strain that comes is a good fit with people's pre-existing immunity, great, probably not all that needed. On the other hand, if there's a shift and people's pre-existing immunity isn't doing the job, and then you add the force multiplier, which is age, to the mixture, then you're going to have patients that are vulnerable. And in that population, pre-exposure or post-exposure prophylaxis can make a big difference. We've seen that with influenza, and I imagine it's going to be quite similar.
Yeah, one of the things that I'm watching very carefully for is what the outbreaks look like in this wave that we're having now in September and October. So those data will be available, I think, in many states in another month or so, summary data. And there you're looking at, how big were the outbreaks? How many residents were hospitalized? Did any residents die? Because it really does look, at least in Ontario, as if there's been this significant shift in long-term care. Remember, they've been more heavily exposed to both infection and vaccine than the rest of us. And there is a shift to really significantly lower attack rates and lower severity of illness when people have them. And so as long as we don't see new variants, we may get some evidence out of the September and October outbreaks that the outbreaks are smaller and significantly less severe, and we don't need to worry about them as much as we have in the past. So it really is, on many fronts, a moving target for medical directors. It's going to be another challenging winter, I think, to sort out.
Understood. So let's move to the next to last slide, please. I just want to make sure that everybody's aware that we'll be holding a more detailed symposium called the COVID Countdown, the latest in safeguarding protection and treatment for vulnerable populations, where hopefully we'll have more opportunity for both detailed presentation as well as audience interaction. But I want to thank those who have listened in for their participation. And then the next slide, I think, will summarize how you can get your CME credit for having participated in this event. And again, I just want to extend my sincere thanks to both Allison and Shmuel for their participation, and to you all in the audience for joining us. Best wishes.